and I thought I'd update you on some of the work we're doing in healthcare worker studies in the UK, and I'll just mainly talk about a paper that's out this week, so it's reasonably current. Get it to move. So the pitch consortium was set up in the sort of early part of the first wave of the pandemic, and it's a study that was based on getting reasonable blood draws to do T-cell work on COVID-19 and using the healthcare workers as they were sort of a leading population to study, especially as they were getting infected. So the primary aim was to understand immunity to natural infection, and then it's soon morphed, of course, into a vaccine efficacy study. The context is that we're linked to the SIREN study, which is a very beautifully designed study of around 50,000 healthcare workers in the UK, with much broader reach. It's across most of the hospitals because we've got a unified health service. So it's quite easy to recruit to that. But the key bit about that is that there was prospective sampling. So many measures of ongoing immunity and protection can be much better studied in a prospective way. Our study was not really powered to do that, just because of the kind of complexity of getting blood draws in and separating out lymphocytes and doing the assays. So we concentrated on a few sites that are shown on the map, and centered in Oxford, and as I said, linked in with the PHE. And we've got I think that's a little bit out of date now, 2000. We continually recruiting to the study. We did think it was going to be over a while back, but it's got refunded. And we've connected up also with our other sites around. We've got a parallel study going on, smaller scales in some of these places, including Bangladesh. And we found that as far as T-cell assays go, the simple ones that we've sort of set up are very robust to being transported around the place. And it's actually quite gratifying to see that T-cell immunology studies can be reasonably comparable, whereas they've got a history for being rather site-specific. So the first things we needed to do, I just briefly sort of talk about some of the background, were just to establish those studies, and some of this was published over the last sort of year or two. So just to make sure that we had robust studies, and we tend to use interferon gamma ELISpots as a workhorse assay. So the spot forming units per million cells is good, and that assay is quite useful, has been useful, because unexposed people we found didn't make a response, even though there's lots of discussion and evidence that there are cross-reactive responses with circulating coronas in this assay. The cells are not able to make gamma over that period. So it's a clean assay, and then we could measure responses, as many groups have done, to different proteins and try and assign some kind of meaning to that T-cell response. And we've tracked that over time. So in the middle bit of the diagram, we've sort of integrated that data with other parameters and tried to understand why people go down different trajectories in their memory, just trying to sort of pass out some of the details of natural memory. And then most of the early work was also used as a comparison with vaccine-induced infection, T-cell responses and antibodies, actually, for that matter, as vaccines became developed locally through the adeno program at Oxford. So those were sort of early phases of the program, which has built up a kind of a better profile over the last sort of 6 months or so. So we also recruited, because we recruited so broadly, and we had people at all stages of disease and subsequently all various types of vaccination. It's been a really good resource for deeper dives into the biology, including these generation of monoclonals. We heard a lot about monoclonals today already. So we created with Gavin Screeton's group and Dave Stewart doing the structural biology, a number of studies around the variants as they emerged, trying to look at the fine specificity and the polyclonal responses. And there's a paper I'll just highlight. I didn't really have time to talk about it, but it's just coming out hopefully very soon, using our cohort as one control in a series of kind of analyses using essentially multi-omics, and then some higher level analysis to kind of integrate those multi-omics to look at some of the things that have already been discussed about gene expression patterns in response to different levels of infection and roles of interference and so forth are all embedded in that study. But it's really a resource paper, I think, if people want to understand the functions of any individual cell or any circulating biomarker. So again, the healthcare workers were largely non-hospitalized and provide the kind of reference point in that. So just to sort of set the scene for the study, I wanted to talk about mainly the one of the things that came out earlier in the year as the vaccines were rolled out in the UK, which the process started in December, was to try and understand the impact of prior immunity. I think everybody knows what this is now, but at the time it wasn't. The healthcare workers in the UK tended to get the Pfizer vaccine, which even in Oxford was a bit strange, but it was just to do with the timing of the rollout. And so this was focused largely on those, and we wanted to understand what the role of prior immunity was, and this is important for understanding the next study I'll show you. So this is, I think, quite a well-rehearsed result, but just to give you an idea of the sorts of data we get using this is an ELISA-based platform, and we've used neutralizing antibodies as well, live newts, and some of these RBD binding assays that are also in the multiplex MSD platform. But essentially, at least at the time that these vaccines were given, which was probably about 6 or 9 months after the original infection, if you look at the people who get one dose, they get up to the level of those who've been previously infected, and people who've been previously infected get a substantial boost, which was roughly equivalent to what you get with 2 doses of the naive or slightly higher. So that isn't necessarily very surprising anymore, but it was actually a very dramatic impact seen initially. And as far as the T cells go, you get actually fairly similar looking results. So I think there was some concern of what would happen after a single dose with T cells, but you actually generate, again, a response that's really easily measurable with this ELISpot assay, or any other assay probably that you wanted to roll at it, which is roughly equivalent, again, to what you get with natural infection. I would say that the T cell responses also decline, like many antibodies have been described to, slowly over time, but it's not a very dramatic drop. So you're left with fairly decent spike antibodies, also M and N, but these are clearly not boosted, whereas the spike is boosted nicely with a huge level of variability, but clearly prior exposure to SARS-CoV-2, which can be subsequently boosted, whereas prior exposure to all the other coronas that are circulating doesn't really impact on that. So that is now I think it's out today, even though it was basically submitted in January, but I think it's been in the public domain for a while. So for the rest of the talk, I thought I'd just run through this paper, which is, I think, coming out. It's already online, but it's coming out in kind of fully edited form this week. And Becky is hopefully on the line to answer any questions that I can't. So this was a look at T cells originally, but subsequently antibodies in nearly 600 healthcare workers. And we took the opportunity to try and understand what had actually gone on in the UK. So this might not be familiar to the audience, but we started with, like every other country, with the conventional Pfizer regimen of around 3 weeks between the first and second dose. And that started to roll out in December of 2020. And then just between Christmas and New Year of that year, the government, the Committee for Vaccines advised the government to extend the dosing interval. And that was based partly on the experience from the adenovirus, which actually there's loads of biological data that suggest extending dosing intervals in the adenovirus is beneficial, including trial data from the SARS-CoV-2 program. But there was no data to support the Pfizer being extended. And in fact, the reasons were to try and get more people getting their first dose. I mean, with data emerging, as I just showed you, that you do get some levels of immunity and hopefully protection from that. And so that we could get more of the population vaccinated in a kind of a slightly different approach to population protection. But it was super controversial and actually lots of antagonism from the medical profession as well as others. And but certainly whatever the politics of it, there was lacking in data for sure. So we tried to fill in that gap. So we did exactly what I just showed you, collect bloods. Well, we had stored them and did these ELISpots for the T cells and some intracellular cytokine staining, and then some fairly conventional antibody assays, ELISAs, RBD binding, and neutralization wherever possible, and tried to see if what we'd actually done to most of the UK population with this experiment. So the first thing we needed to just check was to go back to our colleagues in SIREN who are doing the efficacy or effectiveness analysis in exactly the same cohort. We're just a subset of that, hopefully a representative one, and look at the effectiveness of a single dose, which actually to me was a bit of a surprise after a single dose, as you can see in the left-hand panel, over those sort of 10 weeks, actually you've got quite good evidence of protection. So just for reference, the UK was undergoing a fairly awful second wave at that point of alpha variant, which emerged in Kent at about the same time the vaccine program started. And this was early data from the second dose, but there's tons of other data there now. But that is quite interesting that the T cell / B cell / any other measures that you might generate after a single dose that I just showed you might actually provide some protection. Although that wasn't necessarily the entire point of the study, it's a sort of interesting observation. So what we've done is take blood 1 week, 4 weeks after the short, or I guess for most of you, conventional dosing, and then at 13 weeks, which is equivalent to 4 weeks after, on average, 4 weeks after the dosing, the second dose in the UK version of the long interval, and we've got this intermediate time point. So we hopefully can get essentially equivalent time points. I think critically, basically, we can compare, and over time this becomes kind of the more relevant, the 4 week post second dose, and we're obviously trying to look at much later time points. There's a little bit of data in the study at 13 weeks, but not much, because of the just the timing of getting everybody through their second doses and getting the bloods in. And this is a cohort. It's a bit skewed in a couple of ways. So if you look at the numbers getting short interval, it's only a fraction of the people compared to the long ones. That's because you had to be in an early wave of collecting your vaccine to get into that short course. And then as soon as the government and the hospitals changed the policy, there was a little window for people to get their second dose if they were booked in for it. And then if you were booked in January, you got the longer interval. So there was nothing we could really do about that. We just captured everybody we could. The other feature of these healthcare worker cohorts is that they're very skewed towards women. And of course, the age is kind of working age. But they tend to be, in their 40s. So it's not massively representative of the overall population, but hopefully not. As it turned out, and I'm not going to show this data, the age and sex and actually ethnicity didn't really seem to impact on the results as far as we could tell. So I'll just put that to one side, but it is a critique of the study. So this is some neutralization data from Gavin Screeton's lab. who took our samples from, so this is just after the first dose, then after 10 weeks, and then after the second dose. So you can see a nice boost, and you can see a pretty clear decline. So that's a kind of ancestral strain. We didn't have Delta when we started the study, and Delta hadn't actually emerged. So we tried to cover most of the ground. I think most people who do these studies can sort of interpolate where Delta would lie. But you can, sorry, I'm talking rubbish, that's a Delta there. So we didn't cover all the ground with the variants basically. But I think the coverage of Delta after 10 weeks is pretty pitiful. And we don't generate very good antibodies against the South African strain. But even against the Victorious, we didn't have the Alpha, I think that was the issue. But with the drop off against Victoria is also quite substantial. But I guess that the levels of protection are, as I showed you, are not really paralleling this. So I think there's a sort of a bit of a caution in trying to interpret protection just on the basis of a point estimate of neutralization. And then the interesting features, I think, is essentially what happens with the long dose compared to the short dose. And you can see here there's a pretty clear benefit in terms of overall titer of antibody using the same assay I showed you before. It is not. This is why we needed to split it between previous infection, because the prior infection, it doesn't really have such a big impact. They already get boosted by one dose, and the second dose, whether you give it early or late, doesn't really have much of an effect. Whereas there's a kind of demonstrable impact of a second of the second dose in naive people, and that is bigger when you extend the dosing interval. That's the RBD data. This is N as a control. There's something strange going on here. It's still really below limits of detection, but there may have been some ongoing exposure during this period that the longer dose people were exposed over the sort of early part of 2020. And there's a bit of a decline, as you might expect in the previously infected in their N titers. So that's a kind of one of the key results. If you look at neutralization, so this is just a subset of the patients, but I think the results are pretty clear. So again, we don't have Alpha, but we got the other strains, but there's a kind of 2 to 4-fold impact of the maximum titer, assuming that 4 weeks is somewhere close to your maximum titer of extending the dosing interval. I mean, I think the problem is was sort of, we kind of put out in this slide, is that during the interval over sort of, let's say, between January and March, of last year, the patients who were getting the long dose had very low titers against these variants, so they would have been poorly protected. But in the longer run, they have, or certainly over this part of the second half of the year, they'll have much higher titers, although these are going to decline over time. The reviewers asked us to kind of address question about actual B-cell memory rather than circulating antibody, which is it turns out to be quite interesting. So in fact, if you look at the short versus the long, there's clearly a benefit. That's 4 weeks after the short, that's 4 weeks after the long. So you do improve the sort of laying down of B-cell memory. In fact, there seems to be some general accrual of memory over time as you improve, as you leave the B cell. So these are relatively small numbers, so I think I'm cautious to interpret it, but it's certainly, you're no worse off extending the dosing interval as far as B cell memory is concerned, and you're probably slightly better off. And the overall long-term impacts of that are going to be quite interesting. So the story with T cells is not quite what I'd anticipated, actually. So although it has been reproduced in another study in the UK in the elderly. So if you look at the long dosing, short and at 4 weeks after your boost, you have a bigger ELISpot response to spike. Again, if you look at the controls, it's not really relevant to M and N. but for spike, which is the immunogen, if you've not been previously infected, again, if you've been previously infected, it doesn't really, nothing really matters. You've already got such a kind of substantial response. It doesn't seem to shift much, but there's a small deficit. So certainly not an improvement like we saw with the antibodies, a deficit in the gamma secreting T cells. So I just explore that a bit more. We took the opportunity to do some intracellular cytokine staining on, we can't do it on 500 patients, it's just not possible, but we did it on a decent number. And we took, from previous experience, if you start doing intracellular cytokine staining on individuals with relatively low ELISpots, that you get very little because it's not such a sensitive assay. So there was a cutoff for entry for the ICS study, which we hope hasn't really skewed anything, but just a note of caution on that. So these are the data. So if you sort of look at the total CD3s, if you've got CD4 and CD8, there isn't sort of such a dramatic effect on the CD8s, but there is quite a substantial shift towards the CD4s producing, in this case, IL-2. And there's a slightly more gamma and there's slightly less gamma from the CD8. So I think what this amounts to is a sort of skewing of the response, which is sort of the ELISpot is an aggregate of CD4s and CD8s, and we're only measuring gamma, whereas we know that the different subsets behave differently, and then multiple different cytokines, all of which have got their own role to play. And this is probably the kind of key result. Again, if you've been previously infected, nothing really shifts. It's just kind of the same whether you have a long and short interval. If you do just look at the CD4s, it's just effectively the same data with a different denominator. You can see the same result quite clearly. There's much more IL-2, CD4 secreting IL-2. It's effectively a long-term helper population, which you would hope would set you up well for memory in the future. And effectively, I think what we're seeing is fewer gamma secreting effector CD8s, the way I would interpret the data. There's a bit more gamma in the CD4, and there's a bit more TNF. So what that amounts to is you would hope would be a kind of more polyfunctional response. In other words, cells which can secrete multiple cytokines. And historically in vaccinology, that's been regarded as a good thing to have. The data that prove that are maybe a bit sparse, but the field generally agrees that polyfunctionality is a good thing. And that's actually what we find if you look here. So this is cells secreting all the 3 cytokines we measured. You can measure many more, but just with increasingly elaborate flow. But this is a kind of good glimpse of what's happening, and it's clearly enhanced by the long versus the short in the naive group. And as I've said dozens of times now, that the previously infected group is not much of a shift. So that's a kind of proportional shift in the cells towards a more polyfunctional CD4. These are CD4 cells. You don't really see much of a shift in the CD8s because actually they're harder to capture. Usually it's the other way around with intracellular cytokine stains, but in this particular case, CD4s seem to be relatively easier to capture. So I think that's most of the messages from the paper. So I think this is sort of summary. We think that the extended interval is actually highly protective, and actually the gap during the gap between the doses, you have a level of protection, even though it's clearly lower. The higher interval, the antibodies, the extended regimen produces better antibodies, higher level antibodies. It's not dramatic, but it's clearly measurable compared with the short or conventional interval. And in doing so, you also tune your T cell responses towards helper functions, which could also promote B cell maturation as well as help for T cells and longevity for the overall response. And antibodies wane after each dose, but actually those memory pools are relatively well maintained as far as we can see. That needs a longer look, which is what we're currently doing. We got most of the data in for 6 months, and Becky, who is hopefully here, will be able to talk about that at some point in the future. And of course, we want to understand these longer term issues with other vaccine platforms, in particular the adenos. The one that we're mainly using in the UK is the Oxford AstraZeneca, but we expect that the J&J and others would be similar. So that's the all I was going to say, and I'm very happy to take questions. So I thank well, Susie Dunahee, who's been doing this with me and is the lead author on the paper with me. A very long list of others on this Oxford side, both in the hospital and in the labs, and many groups around the country, including Becky's group in Newcastle, Leeds, Sheffield, and Liverpool. So thanks, and I'm really happy to take some questions.
Thank you, Paul, very much for a beautiful study. Again, tremendous amount of data, and I see Becky is here to answer questions. One thing that struck me is there's been a lot of discussion trying to explain the real world efficacy of the vaccines in contradistinction to various measurements that are able to be done in the lab. And it looks like the antibodies pretty much are tracking with the T cells in your study, although there was some waning after the first dose. Is that accurate?
Yeah, we had a lot of discussion about this because I mean, I think it's quite hard to pass out overall, but I didn't show the data, but during that first period or in the interdose interval, there's actually a kind of two tracks. The antibodies, as I showed, the circulating antibodies are dropping quite clearly. The T cells are not. In fact, if anything, they're slightly better at the end of that period than they are at the beginning. So I sort of took the view initially that suggested that T cells were playing a substantial role during that kind of clearly protected period. But I think it's a bit hard to say that, given that there's clearly B cell memory, there's lots of mucosal defense that we're not measuring and so forth. So yeah, overall, I think we didn't get a perfect correlation between T cells and antibodies in the study. And I think that it may be that these much longer term follow-ups are going to give us more information about what's really doing the work.